Hi, I'm Dr. Lindsey VanDyke. I practice in Mansfield, Texas, and I'm board certified in internal medicine and endocrinology, where I specialize in diabetes. So here in Mansfield, we really don't have great resources for diabetes education. And I teamed up with one of my colleagues at our local hospital to put together this online diabetes education course. There are 5 parts to this whole class, which will take several hours to go through, but I've broken them up into the 5 parts so they're a little bit more digestible. And then, of course, they're there for you all the time if you need to go back and refer to things if you need a refresher. There will be links to educational materials as well on my website, and that's lindseyvandyke.com, where I keep my clinic handouts for my patients. You can always get copies of all of our podcasts and other educational videos through our YouTube channel as well, where it's equipped with closed captioning. All right, so let's get started. This is Foundations of Diabetes Management. This course was designed by my colleague, Nurse Katie Mosteller. She's in charge of diabetes education at our facility. But I wanted to make it available to you by podcast so that it's always accessible, no matter what. All right, so this is a big deal across the world. I don't think that's a secret anymore. So let's start with part 1 of 5. We're just going to define diabetes. Let's start, in fact, with the condition of pre-diabetes. So what is it? Well, it's the phase that comes before type 2 diabetes. Blood sugars are higher than normal, but they're not yet high enough to be diagnosed with diabetes. And we will talk about what those numbers are. Prediabetes is associated with obesity, high cholesterol, high blood pressure, or maybe you've heard your primary doctor refer to you having metabolic syndrome. Here's a question: true or false? Damage to the heart and blood vessels happens after years of having high blood sugars. And you may be surprised to know that that is actually false. The damage begins during the pre-diabetes phase when blood sugars are barely above normal. So what does pre-diabetes mean to you? And this is an important wake-up call for everybody, even those of us who don't have pre-diabetes right now, because it happens more with age. So interventions that we make now will have greater payoff later. Okay, so pre-diabetes, that means you have a greater chance of developing full-blown diabetes. The longer you can stop it from progressing, the better you will do. And so when you catch a diagnosis of pre-diabetes, that is where you really hold all of the power. The interventions that you make in your lifestyle will do wonders for you later. And that's what we want. We want the payoff for later. It also means that you are more likely to have heart disease, which also translates in some ways that you are more likely to have a stroke. And we will talk about these things a little bit more. Okay, we mentioned metabolic syndrome, so I want you to know specifically what that means. That means that you've got a fasting blood sugar that's at least 110. You have an abdominal waistline obesity, the presence of an apple shape. In men, that measurement is going to be 40 inches or higher. In women, that measurement would be higher than 35 inches. So think about what size are your jeans. If your jeans are sized by the measurement of the waist, we want those numbers to be less than 40 for men, less than 35 for women. Blood pressure. People with metabolic syndrome will find blood pressures to be at least 130/85. Frequently, this is much higher. And sometimes blood pressure is our very first warning that something is happening. And we get a prescription for a blood pressure medication, and sometimes it gets controlled and those dots don't get connected. And so the more aggressive interventions to deal with metabolic syndrome and prediabetes, they don't necessarily happen. Triglycerides. This is part of your cholesterol panel, that blood test your doctor does every year. So triglycerides tend to be higher than 150, which, going back to heart disease, when we see triglycerides higher than 150, that is an independent risk factor for heart disease. So aside from mom, dad, brother, sister having heart disease themselves, or eating a high-fat diet, or not exercising, or having these other measurements that we just talked about for metabolic syndrome, triglycerides just at 150 or higher is an independent risk factor. Now, there are multiple types of cholesterol, and there's the good and the bad. The good cholesterol is the HDL. That's your good pipe cleaner cholesterol. We like that to be high, but in people who have metabolic syndrome, prediabetes, diabetes, this number tends to be low, and typically that's under 40, so we don't like that. Women tend to have a little bit higher HDL, and that's by virtue of the fact that they're female, they make estrogen, so if their number is under 50, that qualifies. All right, now type 1 diabetes. Historically, this was thought of as juvenile diabetes, but the reality is it's not just for kids. And what is it? How is it different than type 2? Well, type 1 involves destruction of the insulin-making cells. Those are the beta cells in the pancreas, and this eventually will produce a complete inability to make insulin. That's an absolute insulin deficiency. Okay, so when we diagnose these patients, we see on the blood test that they have antibodies to those islet cells in their pancreas. Those are cells that make insulin. And this is much less common than type 2 diabetes. It only makes up between 5 and 10% of all of our diabetes cases. And frequently, these autoimmune birds of a feather will flock together. So people with type 1 diabetes, they might also have Hashimoto's hypothyroidism. They might also have celiac disease. They might have rheumatoid arthritis. There are a number of things that can come with a type 1 diagnosis. Now, the beta cell rate of destruction can be highly variable. And in kids, we tend to see what I will refer to as a diabetes explosion. You know, they're kind of okay for a long time, and then pow, they land in the hospital, they have a diabetic ketoacidosis emergency, and all of a sudden they need insulin. In the adult, this can be more of a smoldering process. And so you can kind of have this gradual, subtly worsening need for diabetes medications in the adult, or you're on the things that we would normally give for type 2 diabetes, but it's just not quite working. And then all of a sudden, you might get hospitalized and somebody figures out, oh, this is actually a type 1 process. Okay, and in those adults, when we figure out that it's not actually type 2 we've been treating, it's type 1, that's called LADA, which stands for latent autoimmune diabetes in the adult. And it's becoming more common. Now, type 2 diabetes is a much more complicated picture. Type 2 results from a progressive insulin secretion defect. So we get worse at making enough insulin, and that's happening on the background of also worsening insulin resistance, okay? So this becomes kind of a vicious cycle. That means that, you know, you eat carbohydrates, you make some insulin, but you have this early insulin resistance. So you have to make a little bit more than a normal person might need to make to cover those carbohydrates. Here's the problem with insulin. Its whole job is to make sugar go into the cell to eventually build fat. So if we make extra insulin, we make more fat. What does fat do? It worsens insulin resistance, okay? So around and around we go with this problem of insulin resistance. Now, type 2, significantly more common, It's about 90 to 95% of all cases of diabetes. And much like our metabolic syndrome, we have patients who have big bellies. They carry the fat around their organs, that apple shape, okay? This is not the kapow process that you see with a fresh type 1 diabetes where all of a sudden it explodes like crazy, you get hospitalized. This is a gradual process. So if you are seeing your primary care doctor like you are supposed to every year, they will be tracking these things, and this won't be a sudden surprise. A hallmark of type 2 diabetes is physical inactivity because, again, like building fat, resting constantly like we do in our computer, desk, television, couch lives, it breeds more insulin resistance, okay? And if we were to compare heart disease risk in type 1s versus type 2s, it's the type 2s that have significantly higher cardiovascular disease risk, okay? So here in the bubble, we delineate how it gets discovered. Okay, we already talked about routine screening, but another time it can really present itself is if, let's say, you are hospitalized for something else. You get pneumonia and you are really sick, or you have a major surgery. That's a significant stress on your body, and that's a situation where you can't make enough insulin to deal with the stress-related blood sugar that is going on. And so you'll have patients coming in the hospital and they have disproportional high blood sugars for what's going on with them, and that's how we figure it out. Okay, so this is a really complex picture, and it's on here because, as I mentioned before, type 2 diabetes is a very complicated disease process. It's multifactorial, okay? It has many different causes, multifactorial in nature. And that means that it's not just about your pancreas, okay? Your liver plays a role, your gut plays a role, your skeletal muscle, your kidneys, your fat cells, your brain, they all play distinct roles that can contribute to the worsening of the disease. And so if you were to look at how we treat type 1 diabetes versus type 2 diabetes, you say, oh, type 1, they need insulin. Boom, done, taken care of. Type 2s, oh my God, you have a guy who's on type 2 diabetes, he's got 4 or 5 different drugs, including insulin. And this is why. That's because many of the drugs that we have target all of these different components of the underlying disease process. So don't worry about having to memorize all of these things. All right, so let's compare, just to kind of drive this point home. How do you compare type 1 and type 2? So type 1 tends to be quick onset, this explosion of diabetic ketoacidosis, okay? Can happen any age. It's more frequent in the young folks. Patients tend to look either thin or have a normal body shape. Common that they get hospitalized with that ketoacidosis. We see the antibodies present. They don't have the ability to make insulin anymore. Whoops. And then in twins, about 50-50 that both twins would have it, and it only makes up 5 or 10% of our population. So now to recap, type 2 tends to be a gradual onset. This is the most common scenario for diabetes in adults. These patients tend to have gained weight. They tend to have obesity, and they tend to carry that fat in the apple shape. Diabetic ketoacidosis is rare. It can happen, but there's a similar condition to diabetic ketoacidosis that many type 2 patients are familiar with, and that's called HHK. That's an acronym you don't need to worry about, but the idea is that it's very similar in nature to diabetic ketoacidosis. So if you're a type 2 patient and you go, well, I was hospitalized, they put me in intensive care, I had to have an insulin drip, you had that condition. most likely. Okay, these patients do not have antibodies to their insulin-producing cells in the pancreas. They do have the ability to make insulin. Sometimes they make a ton of insulin because their body's really working to overcome that insulin resistance. Sometimes they have normal insulin production and it's just not appropriate for the amount of blood sugar control that they need. Or their diabetes has advanced to the point where they've made insulin so hard for so many years, and the body just kind of starts to poop out. Interestingly, when we look at family studies and twin studies, like 90% of twins will end up having type 2 together. And clearly, this makes up the majority of our cases in diabetes among adults. It's more prevalent. All right, so how do we diagnose it? Now, earlier I said we would talk about what blood sugar criteria are needed for diabetes diagnosis, and this is it. Now, frequently, your doctor is going to talk about using the hemoglobin A1C, and when that number is greater than 6.5%, that counts as diabetes. Whereas when we compare that to a pre-diabetes stage, you're looking at an A1C that's about 5.5 or maybe a little bit higher, 5.8, up to 6.5. Okay, so that's the crossover. 6.5, we're diabetic. Or your doctor may have checked blood sugar with from the vein first thing in the morning, and if that is higher than 126, that counts as diabetes. Remember how we talked about in metabolic syndrome, you're not quite there yet. You're not at diabetes yet. Your fasting blood sugar is 110 to 125. Sometimes, and this is most common in the case of pregnant women, we feed them a drink called glucola, which is real sugary, disgusting, syrupy kind of thing to drink. And then we test the blood 2 hours later. And if that's higher than 200, that counts as diabetes. Or if we're checking you at random anytime and your blood sugar is higher than 200, that counts as diabetes. So let's talk about the ABCs of diabetes. So A, that hemoglobin A1C or AEG, that average estimated glucose. The frequency with which you have this done depends on your results, but typically we do this every 3 months because that's the window of time it measures blood sugar. And this is an example of what that looks like. Your blood sugar, your red blood cells attract these sugar molecules to them. And so red blood cells that are older have more sugar molecules that stick to them. Red blood cells that are newer have fewer sugar molecules that stick to them, okay? So that is the hemoglobin A1C. Why do we care about it? What does it mean to us? Well, think about it in terms of traffic lights, okay? We got green. Green is good. Green means go. Yellow is, okay, be careful, caution, something's happening. And red is, oh crap, stop everything, we need to fix this problem. Okay, so serious elevated levels of blood sugar, 11 or higher. I mean, I've seen A1Cs are as high as 17, 18%. But anytime you have double-digit hemoglobin A1C, we have got to stop the presses. It is time to get this under control, okay? And it typically deserves a little bit of insulin, because what insulin does when A1C is that high, it helps relieve the body of sugar toxicity, and we need to let the body recover from that. It causes a lot of inflammation, and so we give short course of insulin frequently to kind of calm everything down, bring your insulin sensitivity back up, and then we can transfer you over to other medications. Now here we are in the yellow zone. This is elevation. A1C is about 8 to 10%. This is not great news. I would still consider a little bit of insulin here for starters. And when an A1C is 8 or higher, you're looking about blood sugars in the 200s, easy. Okay. Green, we love to be in the green. Okay. A lot of societies are saying your A1C, or beg pardon, your diabetes is under control when that A1C is 7 or less. Okay. And that means that your average blood sugar is less than 170. All right. Less than 170. That's gold. And then in the deep green section here, we have the non-diabetes levels for your reference. Okay, these blood sugars are running, 65, 70 up to 135, 140 after you eat something. And those A1Cs would be 4 to 6%. Now, remember we talked about prediabetes falls in that, mid 5s to low 6s. You're still not diabetic at that phase. All right, B's, we care about blood pressure. This is a really big deal. Blood pressure is the force that the blood inside of your vessels exerts on the wall of that tube that is your blood vessel, okay? When the force is high, your heart has to work harder. High blood pressure increases our risks for heart attack and stroke. It causes problems in the retina. It causes problems in the kidneys. It's no good. We want to make sure that blood pressure is controlled. And the American Diabetes Association has very specific guidelines for that. So anytime you are seeing a doctor for any reason, they need to be checking your blood pressure. The guidelines from the ADA at this point in time is targeting 140 over 90 or less. There's some data that is suggestive that 130 over 80 or less is okay. We have to balance these goals with the risks they impose to the individual patient. So a 130 over 80 is not for everybody. And that's a discussion that you have with your doctor. All right, again, blood pressure, ABCs. So the top number, that is called the systolic blood pressure, all right? The bottom number is called the diastolic, that's the smaller number, blood pressure. And when we categorize these ranges of numbers, we give them a stage of hypertension. And hypertension just means high blood pressure, hypertension. So when you're normal, when you have numbers that are 120 and 80 or a little below, that's great. That's awesome. Keep doing what you're doing. Make sure you have a good, healthy lifestyle. You exercise, you eat fruits, vegetables, lean meats, all of that. When you are between 120 and 139, over 80 to 89, this is that pre-hypertensive phase. So if you're doing a pretty good job with your lifestyle, you want to keep it up or maybe intensify what you're doing there. Now, 140 to 159 over 90 to 99, I don't really care that you know that this is stage 1 versus stage 2, but this means if you have diabetes and you have these blood pressure readings, we have got to deal with that problem. Okay, because it's not going to buy us time or health in the future if we do not deal with it now. And certainly if you got numbers that are, higher than 160 over 100, we don't like this at all. Sometimes we hospitalize people for this, usually requires multiple medications. All right, C in the ABCs, this is our cholesterol. So cholesterol gets checked at least once a year, and we care about this because cholesterol causes heart attacks. And how do we deal with it? Well, there's a lot of data that shows that the more plant-based diets have better heart disease outcomes. Okay, so the Mediterranean diet has been proven in trials to reduce death by heart disease. And so that's going to be your vegetables, especially those leafy greens, things that are really brightly colored, your carrots, your pumpkins, your berries, okay? Fruits that have lots of fiber, and nuts, of course. Now, nuts are high in calories and high in fat, but they tend to be good fats. We do a little bit of eggs and a little bit of meat, and when we do the meat, we prefer that it's fish, wild-caught fish, or free range poultry, and venison is quite lean as well. Now, in terms of oils, if you want to consume healthy fats, you stay away from fats that are solid at room temperature. Well, guess what? That's coconut. Coconut oil is solid at room temperature. Butter is solid at room temperature. Things like olive oil, avocado oil, these things are better because they are liquid at room temperature. So think, if it's hard at room temperature, it's going to end up being hard in my arteries. It's no good. All right, so things to avoid: anything that comes in a box or a bag or has a ton of sodium in it, something that comes out of a soda can, all the delicious things that we all love to eat, okay? Terrible for us, causes a lot of inflammation, makes this cholesterol deposit worse, all right? Grains, breads, beans. We want to eat whole grains. So whole grain breads are okay. Beans have a fair amount of fiber in them. And then dairy, we want to minimize dairy, again, because it's full of animal fats. Cheeses are delicious. I love them, but I want to try and minimize my intake of cheese, which is clearly not the American way. But I want to minimize the intake of cheese. And when I do eat cheese, I like it to be soft cheeses, not hard cheeses. Let's dissect a cholesterol blood test. Okay, that's called your lipid profile. Lipid means fats. We have different kinds of fats that we also call cholesterols in our body. So when you look at that lab report that your doctor runs for you, it'll give you these desirable ranges. And I'm going to tell you right now, these ranges are not good enough. Okay, heart disease is the #1 killer in this country. It kills somebody more than one every minute. And it's probably more like one about every 40, 45 seconds. And I'll give you a hint. We talked about triglycerides. When they're higher than 150, that's an independent risk factor. So you want to keep those suckers down. Your good pipe cleaner cholesterol, that HDL, nice and high, 50, 60, we love that. And then LDL, this is the bad news. This is the thing that deposits in the arteries. This is the thing that causes blockages that produce heart attacks. So how low can you go? Well, the data suggests as low as you want, because there's no evidence that there's any bad side effects of having an LDL number that is super, super low. So here's the breakdown. The average LDL of anybody having a heart attack right this minute in this country is about 90, 91. Okay, guess what? 90 falls underneath this parameter of desirable LDL. That's garbage. So we do know from lots of data that we've gathered over the years that if we push an LDL down through diet, exercise, other lifestyle interventions, and #1, medication, it's extremely potent. If we push that down to 75, we can stabilize the plaques that are in the arteries now, so they will not continue to grow. And while that's stabilized, the body's natural processes of cleaning that stuff out will continue to work. So eventually you get a better cardiovascular risk profile. You get better odds against disease. If we push that down to 50 or lower, we will see the body regress the soft plaques that are inside. So when I get a diabetes patient, if they are not on a high-intensity statin medication, they get one. And if they are not at goal on that medication, we fix that problem. Okay, so it's a very important ongoing conversation that you must have with your doctors who are taking care of you. I don't really care about this ratio. Forget about that. All right, let's talk about what the American Diabetes Association recommends to us. And the nice thing about the ADA is they update their recommendations every year. Other professional societies, there might be 2, 4, 7, 10 years in between new published guidelines. And that's a problem because everything's always evolving. So, American Diabetes Association suggests that for patients who are not pregnant with diabetes, that the A1C target should be individualized. And that decision depends on how old you are, how many other medical problems you have, and how many side effects you get from your diabetes treatment. Okay, so sometimes it's more risky to have really strict A1C goals of 6.5 or 7. For certain patients, it can cause some damage. So for somebody who's young and healthy like me, yeah, A1C is 6.5 is awesome. For somebody who's 85 years old, has had a couple of heart attacks, has problems with falling, is really high risk, yeah, maybe an A1C closer to 7.5 or 8 is appropriate. Okay, so what do we want to see? In general, on average, we want to see that A1C 7 or less, or an EAG, that estimated average glucose, less than 154. Before a meal, whether it's breakfast, lunch, or dinner, we want you to have a fasting blood sugar between about 80 to 130, 90 to 120, okay? 1 to 2 hours after starting your meal, it needs to be less than 180. So that's why I make patients check 2 hours after their meal, because I need to know how high is it going during those times. We'll talk a little bit more about these postprandial targets if A1C is not met. That really has to do with fine-tuning the diabetes plan to optimize that A1C. Now, in order for everybody to really understand how all of this stuff matters, we need to talk about how the body gets and uses energy. So let's say you eat your sandwich and you chew it up, you swallow it. The saliva has enzymes in it that start the breakdown of the food. The stomach makes enzymes to break down food. And it ultimately gets broken down into its ultimate building blocks, okay? It gets broken down into glucose, gets broken down into the lipids, the fats that we talked about. It gets broken down into amino acids, proteins, and those kinds of things. And all of those things can enter the bloodstream and travel to the necessary cells to be used. Now, glucose is our primary fuel source. In fact, your brain refuses to use anything other than plain glucose as its fuel. That's why people feel bad when their blood sugar starts to get low. Now, when blood sugar goes up, when the glucose is entering the blood from the gut, the blood sugar goes up, and that's a signal to the pancreas, it's time to make insulin. We need to push that sugar into the cells, out of the bloodstream and into the cells so they can be used. Now, insulin kind of works like a key. It opens the door to these cells so that the sugar can get in, okay? So we mentioned a little bit about low blood sugar, why people feel poorly. It has a lot of causes. All right, so drinking alcohol can cause low blood sugar. If you're not eating enough, it blocks your body's ability to make sugar from stuff that we store in the liver, right? So we have backup plans in the body for times of famine, right? How we are able to feed ourselves. Certain medications can cause low blood sugar. Certainly if you take insulin without eating anything, it can cause low blood sugar. And in patients who require insulin, it's more frequent to have these episodes of low blood sugar. And the treatment, this is a really big deal. And my patients have a handout they get from clinic. It's also uploaded to my website, lindseyvandyke.com, under educational materials. And it does guide you through the proper way to treat a low blood sugar, because it's really easy. to do it the wrong way. And when we do it the wrong way, then we end up with these sky-high blood sugars, and it's a disaster to try and chase those back down to normal. So here's how you do it. You have a low blood sugar. You've measured it on your finger stick or your CGM. And you go, okay, I need to treat this. So you need to eat or drink 10 to 15 grams of glucose. And we'll tell you what that means. And it's best to do this rescue orally rather than having an IV push of sugar solution or having a shot of glucagon. So you eat it or you drink it. If you drink it, your recovery will be a little bit faster because it's easier to absorb that stuff. So what is 10 to 15 grams of glucose? That's going to be 3 to 4 of the glucose tablets. Each tablet is 4 grams of glucose. If you have lifesavers, we're talking 8 to 10 lifesavers. Raisins, super useful. 2 tablespoons is all you need to eat. A lot of patients like to keep the little cans of juice around because they're quick and they are already small enough. You only need 4 to 6 ounces of fruit juice or of regular soda. 1 piece of fruit like an apple will do it, and 1 cup of low-fat or non-fat milk will do it as well. And the reason is because when they take the fat out of the milk, all that's really left is some protein and some sugar. So my recommendations for the patients are stash the tablets in your car, at your office, by your nightstand, anywhere you think you might need to grab them real quick. And keep the little cans of fruit juice around as well in those kinds of places. So you're always able to treat appropriately. What's not outlined here and what makes this rescue so difficult is once you've done that, once you've had your juice or your tablets, you have to sit on your hands for 15 minutes because that's how long it takes for the body to absorb and get that sugar to the bloodstream. And then it's accurate to be able to check your finger stick again and see, did I adequately treat this or not? Did I make it to a blood sugar of 100 or not? And we can talk about more of these details a little bit later, but that's fundamental. You have to sit on your hands and wait because your inclination when you have these low blood sugars is to just eat everything in front of you. And we need to not do that because it can really be a mess. All right, how do we prevent future low blood sugars? This is also equally fundamental. We need to make sure that we're having an appropriate match of carbohydrate intake and insulin dosing. And if you're if you're a runner, if you're doing a lot of activity, you may need to snack. You may need to slow down your insulin pump, all kinds of things, because we don't want you passing out in the middle of your exercise. We always want to avoid using high-fat foods. Chocolate is just terrible for rescuing a low blood sugar. And the reason is because fat gets absorbed more slowly. So that 15 minutes I'd make you sit on your hands, we're talking like an hour or so before that blood sugar would really go up. We already mentioned carrying some type of carbohydrate. It's easy to get to, easy to use, keeping something at the bedside, at your desk, in the car. And this is really key. If you have diabetes, you need a bracelet. You need an identifier because if you're found in a car wreck or on the side of the road and you're passed out and you can't tell anybody anything, they need to know what to do for you. And you may need a sugar shot, basically, to get you to wake up. I love it when patients keep logs because I love data, and those days of having to handwrite logs, those are going away because continuous blood glucose monitors are becoming the norm. And as long as I can see the data, then I'm happy. If I can't see the data, then I'm totally flying blind. I can't help the patient in the clinic because we don't know what we're doing. We don't know if blood sugar's high or low or fine or what. So what do we not do? Like we said, we don't keep eating after that first treatment. We wait and we check. We don't keep eating until symptoms disappear. We don't like to skip meals because we want to be creatures of habit with diabetes. We want to make sure that we keep to a schedule, and so we can understand how medications are going to affect us and predict that. And if you're having problems with low blood sugar, you cannot be driving. You can't. You need to check your blood sugar before you get in the car to go anywhere, because what would be the worst thing in the world? You pass out behind the wheel and you cause a wreck and you harm yourself and other people. Okay, this is a little bit more detail about what we mentioned before, right? We check that sugar. We're feeling bad. We check the sugar. It's below 70, got to treat, okay? We can eat something. We're going to have our 15-gram replacement, our tablets, our lifesavers, our fruit juice or soft drink, okay? If you are a caregiver for somebody and you find them passed out and you can't wake them up, obviously they can't go eat anything for rescue. That is why we give out the glucagon pens. It's like an EpiPen. You go stab them in the thigh and it's going to bring them back to life. Okay. And again, the hard part, the sitting on your hands for 15 whole minutes. And that's when you check again. If that blood sugar is still under 100, then we need to go back to steps 2, 3, and 4 until we get that over 100. Okay, so not everybody gets one rescue and they're done. Sometimes you need 2 rescues. Sometimes you need 3. Your body's going to tell you. And while you're sitting on your hands, waiting for your 15 minutes, you need to think about what happened. Why did this happen? Did I miscalculate my insulin dose? Did I skip a meal? Did I change my exercise? Did I start a new medication that's interfering somehow and causing low blood sugars? We need to figure out why so we can treat that underlying issue and avoid low blood sugar later. So let's talk about the opposite problem. High blood sugar or hyperglycemia. That's any blood sugar that is above normal. So right here, this graph is a tracing from a continuous glucose monitor. And this is showing, it takes a sample every 60 seconds or every couple minutes, depending on the model. It shows us what this guy was doing throughout the day. All right, whoa, here's a meal. He ate something that had a lot of naked carbohydrates in it and shot right into the bloodstream. And then he gave the insulin after eating. And so this is a problem because that's a late administration, but it works, right? So here it's coming down, insulin's working, it's unlocking those cells, it's shoving the blood sugar into the cells. And then we have a little bit of an overreaction before our next meal. We have another meal here, we eat, okay, we took our insulin as appropriate. We didn't have naked carbohydrates, so we didn't shoot up above this 200 level mark. Okay, and on our way back down. So what does it feel like if you're up here? Especially if you're a brand new diabetes patient and you're up there all the time. You feel thirsty all the time. Your vision is blurry. You feel like you're peeing all the livelong day. You feel hungry all the time. And let's go back to our different types of diabetes. Type 1, why is this happening? Because you can't make enough insulin or you're not getting enough insulin from your shots. Type 2, you have a lot of insulin resistance. So your body's really trying to punch out that insulin and it's just not enough. It's not enough and that blood sugar keeps going up. Did you eat more or exercise less? Or do you have a major stress event? Did you have surgery? Did you have an illness you got hospitalized for? That makes your body produce a lot of cortisol, and that'll make your blood sugar go right into the stratosphere. And there's this other thing we want to talk about called the dawn phenomenon. Again, this has to do with your body making cortisol, the stress hormone. We think about cortisol only as a fight or flight kind of thing, but cortisol plays a lot of really important roles in your body just in normal life. In fact, between 3 a.m. and 6 a.m., we make a surge of cortisol. That's a normal process every day. And that is what is called the dawn phenomenon, because what happens when you make a surge of cortisol? You're going to have a blood sugar rise. So these patients get frustrated that they're waking up with high blood sugars and they cannot figure it out. And so people who have really strong dawn phenomenons, we need to make changes to how they take their medications, or we need to put them on an insulin pump that can account for that problem at that time of day. So, like I said, the treatment for it depends on the cause of the problem. We already touched on what happens when blood sugar is high. It causes damage to your retina in your eyes. We talked about how it causes problems with the kidneys, and people get chronic kidney disease from their diabetes if it's uncontrolled. You poor guys, you're going to get erectile dysfunction for the same reasons that the kidneys go downhill. It's because there are tons of tiny, delicate blood vessels in the penis as well as in the kidneys, and sugar hits them both the same way. So kidneys go downhill, erectile function goes downhill. It's no good. Legs and feet, again, you have these little delicate peripheral vessels that can be attacked by the blood sugar. The nerves are a similar thing. That's the diabetic neuropathy. People have numbness, tingling, burning pain, pins and needles in their feet, sometimes in their hands. We call that like the stocking glove distribution. It's in the feet and the hands. Women can also have reproductive problems from consistent high blood sugar. You can have dryness. You can have a lot of UTIs or yeast infections too if blood sugar is not controlled. And we did mention already the significant risk of heart disease among our diabetes patients, and closely related to that, of course, is stroke. So controlling that blood sugar, controlling that cholesterol, controlling that blood pressure, reduce these risks of complications. And if we do that well, you are not going to have diabetes like your grandma or your dad had. You won't end up on dialysis. You won't lose your vision. You won't lose function of your feet. We just have to get ahead of it early. Early. So that concludes part 1 of the 5-part series for diabetes education. And I will conclude this here, and we will resume with part 2, monitoring and self-management.